I am Dr. Frank Pieri. Thank you, first of all, for inviting me back. I always enjoy speaking with NAMI, and I'm a huge supporter of the organization for a whole bunch of different reasons. So last year, for those of you who were here, may remember that I gave a talk that was titled Psychotic Disorders, Insight, Acceptance, Compliance, and talked about that in order for someone to ultimately become compliant with treatment, they have to have some insight into the fact they have an illness and then accept the fact they have an illness. So they're very causally related. And there are biological reasons for that. Some of it's inherent in the illnesses that all of you have mentioned. But what then occurred last year, which I thought was great, was after I finished my formal presentation, we got into, I thought, a very good discussion that kind of dovetailed into treatment. And so this year, this is sort of part two in many ways of what we started talking about last year. I'm going to put a disclaimer on the slides, and I'm glad you guys have the handouts because the slides are very dense, okay? And you can take these home and you can spend some time with them. The slides are pulled predominantly from one of the main, if you look at the last, maybe not the last page. The last slide here will list what I pulled these from. There are two main sources for guidelines. There are many sources for guidelines of treatment. The one that most people are aware of and the one that we tend to use in psychiatry is the American Psychiatric Association treatment guidelines. For all of the things you've mentioned and much more, almost anything that you will find in DSM-5, there are treatment guidelines for those diagnoses. These algorithms that I have given you tonight are from another project. It's called the Texas Project Treatment Algorithms, okay? It's also a highly respected treatment algorithm, and if you compare this with the APA guidelines, they are basically very identical. And the reason I pulled these from that project is because they did a really nice job of the graphics. And when you look through this, in my mind, this is better, and I'll deny I ever said this, than what the APA did in their guidelines in terms of presenting the material. So that's why I've given you these things. So what is my take-home message to people about these disorders? And the disorders that I'm going to focus on tonight are mainly schizophrenia and schizoaffective disorder, bipolar disorder, and major depression. Okay, those are the three I'm really going to focus on. Many times it appears that what are the words that are frequently used? Oh, I was supposed to give a background of why I'm up here talking. So before I do that, let me tell you my background. So I was trained in medical school at Loyola University in Chicago. I did my residency at the University of Chicago, have been on faculty at Northwestern, was the medical director of a state hospital in Illinois, have also been in private practice in Chicago. Prior to being at the University of New Mexico, I developed their behavioral health in Alamogordo, New Mexico. For 6 years, I developed their behavioral health program in New Mexico. I fell in love many, many years ago when I was 2, not really. That was with Santa Fe, and had a second home here. And the dream was always to come someday when career allowed me to come and work out here. So that's my background. So I've done urban medicine for most of my life, some academic medicine, but I also now can say I have real experience in rural psychiatry in New Mexico. Now I'm at the University of New Mexico. I'm an associate professor. My job is that I'm medical director of the COPE clinic, and COPE stands for Chronic Ongoing Psychotic Episodes. So this is what I do all day, and deal with all of the issues that come up around this. I also work in the psychiatric emergency services at the University of New Mexico. So that's kind of where I've been and where I am right now. And I live in Santa Fe. I'm a Santa Fe resident, so I commute back and forth. So I'm going to go back now that you can have some idea of why I can talk to you about this. So my point tonight is to try and give you some insight into not the down and dirty treatment, though you have that here. So when you go home and you want to kind of get some idea of what the algorithms are out, they're here for you. But I'm trying to give you an idea of what goes on, and it's a very scary place, in a psychiatrist's mind when they're sitting down with someone and what's going through their head. Because a lot of times it seems like what we're doing is, quote, treating people like guinea pigs, unquote, just throwing medicines at people. What are some of the other things? That this is not a science-based specialty or profession. So I'm trying in some ways to show you what the science of psychiatry is. And there is a science behind it. Are we where we hope to be or wish we were? Absolutely not. And I will probably not be alive when we're at the point that I think we will get to in terms of very specific treatments for very specific individuals that are better tolerated with fewer side effects, where we will have diagnostic tools to be able to take what we're now calling schizophrenia in this broad term and be able to hone it down in a lot more specific biological ways, much like we're seeing right now with, for example, cancer treatments, where I truly believe we will get there at some point. We are nowhere near there at this point.
Bet I don't.
So that's what we're looking for, okay? But we do have science behind what we're doing, and I guarantee you, I've been doing this now for 33 years, and it has changed tremendously in that period of time. So, having said that about the science part, there is the art of medicine. And so we start with the science, and then many of these other decisions that get made along the way are really the art of psychiatry, right? Because it depends on the person we're dealing with. It depends on the comorbid problems. It depends on the person's age. You don't talk to somebody who's 20, who's first diagnosed, the same way you would talk to somebody who's 35. And what we do is then in conjunction with things like therapy. And the question then becomes, what type of therapy? And what's going to work for one person is not going to work for another. And so that's what the purpose of this talk is, okay? I strongly encourage this to be a dialogue tonight, because I guarantee you these slides are not exciting, okay? They have a lot of information, but they are not exciting, okay? And like I said, you can go home and look at the slides and spend time with a lot of the dialogue that's in these slides. And they're pulled right out of the guidelines for you. But what to me is most important tonight is for me to kind of go over them, but to get questions and carry out a dialogue about where each of you are at in dealing with, if you have a family member, a loved one, yourself, whatever, who may have some of these problems. Okay? Does it make sense? Yeah. Okay, great. So raise hands, don't pop. Yes, sir.
Could you introduce a little bit about the algorithm system?
Absolutely. So let me show you. So I would, once again, you all have handouts, thanks to Tom, because I think when he saw my slides, he probably said, "Are you kidding me?"
They look the same as our handout.
Oh, okay, all right.
Explain a
So,
lot.
okay, so but at least you can probably read them a little better. And when you get home, if you have a magnifying glass. But Tom did a great job of
yeah, this is great.
So this is what I mean by an algorithm. Okay, so the first algorithm that I've put up there, if you look on page 7, right? Okay, oh, there are my resources. Okay, on the page before page 7 are the 2 resources that I am pulling these from. The American Psychiatric Association Treatment Guidelines and the Texas Medication Algorithm Project Procedural Manual Treatment Guidelines. That's a long one. But, so if you look at this algorithm, okay, what it's saying is, let's start at the top. So the first thing you would start with is, what is this person's diagnosis? And many times, that is not an easy thing to determine, right? Because that's why a lot of you have probably heard, oh, well, you know, your son has bipolar disorder. No, you go to a different psychiatrist and it's schizophrenia. Then you hear, well, or you hear at first the person's depressed. And that may be true, but then 2 or 3 years later, the clinical picture changes, things happen and evolve, and oh, by the way, that person is actually bipolar. And that may be why some of the medications that initially looked appropriate aren't working, because it's not working because it wasn't necessarily the right diagnosis, not because anybody was incompetent or a bad psychiatrist. It was because these are moving targets. Think of your own self and your own health and your own body. You're not snapshots, you're movies. Is your body the same way today as it was when it was 20? Right. So, and this is really no different. This algorithm approach. If I gave you a talk on diabetes, I guarantee you there's an algorithm on how you treat diabetes. If I gave you a talk on the treatment of hypertension, this is what you would see. And this is exactly what all of the managed care companies and all of the insurance companies look to when they're evaluating not only these illnesses, but treatment of diabetes. If you want that brand new medication for diabetes that just came out on TV in the commercials, I guarantee you that brand new medication is way down here. And you better be able to prove you've gone through all of these steps and it's failed or not been tolerable before that company is going to give you approval. Just like in this particular algorithm, it's hard to see, but the very bottom of this algorithm, what's the treatments towards the bottom? ECT and clozapine. Okay? For those of you who know clozapine is a very effective medication, but can have some potentially serious side effects that need to be monitored for. And therefore, it is not a first-line medication. It's down the road, and it's not appropriate for everybody. Because unfortunately, if someone can't be compliant with a treatment regimen, that medication can be very dangerous. Okay? So that cuts out a lot of people at certain points in their illness, right? But if you look at the top, what the two, oh wait, I've got the wrong order here.
It's the last page on this.
Oh, you're right. Sorry, I was looking at my slide. Let me find
In hell. Nope.
So if you look at, this is the bipolar disorder one, okay? So what's the first thing I want to do when I'm a psychiatrist and I come in? Well, I want to listen to that person's symptoms. I want to get a history that includes what's their experience to date. What are they telling me they're complaining about? What is the family telling me, right? Because inherent in psychiatric disorders frequently is what I experience as the patient is not matching up with what other people are seeing. Insight, right? It's different. And so when you tell me I'm being angry, irritable, and aggressive, I'm going to turn to you and say, I have every reason to be angry, irritable, and aggressive because you're being a jerk, right? How many times have you heard a version of that, right? So that person may have a reason to be irritated to you, but the degree is exaggerated, right? The reaction is extreme. So part of my job is to figure out, okay, is that part of the illness? Is this a family dynamic where, this person may have a reason to be that angry? But it makes a difference in my mind if I decide first, is this person bipolar or is this person got a major depression? One, because that takes me down a whole different tree, right? And there's danger if someone is bipolar and I give them, let's say, an SSRI, an antidepressant, in that family. It can precipitate a mania. So I've got to look for that. Sometimes I got clues. I may get family history. I look for developmental history. Sometimes I don't. And does it happen at times that I might prescribe something and I see somebody cycling up? Absolutely. Because there was no hint that was what was really going on. So the key is for people to keep in touch with me, that I see the person frequently enough when I'm starting a new medicine that I can pick up on these subtle things, right? So if I decide this is a bipolar person and I think they're hypomanic, right, then I'm looking at things like lithium, right, or Depakote, all probably some of these medicines that all of you are familiar with that are standard tried and true medicines. And I hope, as a psychiatrist, I really hope that I can get away with one medicine, right? I hope. Unfortunately, the state of the art these days is we do not have frequently medicines that I can get away with just one. But that's what I strive for. The fewest number of medications at the lowest doses that are effective with the fewest number of side effects. Bar any. That's the principle of treatment, okay? But unfortunately, as you go down this algorithm, what you see is a lot of times it doesn't work that way. I can get on board maybe a medicine that helps with the mania or the hypomania, but guess what? It doesn't help with the depression, right? So then do I add an antidepressant? There's literature that says that can be helpful. There's also still literature that says we're not sure so much. But if I've got somebody who's depressed in front of me and I'm listening closely, am I going to try an antidepressant that I don't think may precipitate a mania? Absolutely. But that's the art of medicine. Yes, I can go to this algorithm and prove to you that that's a reasonable step, but for another patient, I may not do that. Now, why wouldn't I do that if I've got two people in exactly the same place? Theoretically, right? Because maybe in one of those patients, I have a higher index of suspicion that they are more sensitive to medications. Okay? Maybe the way they react to the medicine, I've seen with like lithium or something else, their sensitivity is really intense. The way they metabolize that medicine can be really problematic. Okay? Maybe I know that this person is a methamphetamine user, right? Or an IV drug user, or an alcoholic, or they're very non-compliant with medication, or they're homeless, and therefore the reliability of their compliance. Does that have to factor into what medicines I'm going to choose? You betcha. You betcha. Yeah.
If I can ask a question,
Sure.
where does due process come in right there?
Due process of?
If you're locked up in behavioral health.
Well, there are certainly situations where it is deemed that we are concerned about that person's safety to themselves or to other people, or to that they're unable to care for themselves. The state of New Mexico is very clear about due process. So as a psychiatrist, I can issue, if I have sufficient concern, and that concern can be brought to me by the patient. Usually it's based on the patient's behavior, family information, law enforcement. There are a variety of factors. And what that certificate allows me to do is to say, I have sufficient concern for this person to have them brought in, usually to the emergency room, for an evaluation to see whether I have grounds where I can keep that person for up to 7 days to determine whether that my grounds of concern is accurate. Okay? But within that 7 days, if I'm going to keep that person, I have to file to the court, right? And the court ultimately becomes the decision maker. I present my case. That individual who's a patient has their own attorney who will represent the patient. The patient will get to testify. And ultimately, it is a judge who makes that decision, not mine. Okay? But the concern starts with my medical concern for that patient. Does that make sense?
It does, except for the literal definition of the word communism. If you have any type of heads up that they're not an alcoholic and going to AA, if I know very perceptive people are,
Yeah.
I mean, you see everything. If there's a bubble above, you see everybody's breathing and their lips move and their eyes. But if you know about a definition of communism, there is one.
Well, these are very complicated issues, and it's never as straightforward as I'm describing it, because there are all sorts of factors that come in. But it's certainly a very valid question that we struggle with all the time, because obviously the ideal situation is that everybody's on the same page, everybody agrees. That's not generally what happens. So anyway, so this is the bipolar disorder part. Now, also, if you look, and let me see if I can find that slide here. So this is the ongoing algorithm. This is if you've got somebody who's bipolar, who's depressed, okay? This is if you start with somebody who's mood stable or manic or mixed, okay? So then you get this. Now, many people get concerned that psychiatry only throws medicines at people and that's all we care about, okay? That is really not true. What we have is psychiatrists are the medical part of mental health treatment. That is what we do. That doesn't mean we aren't trained to do therapy. Doesn't mean that we don't see its value, that we don't believe in a multidisciplinary approach. But the reality is there are not many of us around. How easy has it been for you guys to, right? And now we're lucky because we can also get some really good psychiatric nurse practitioners, right? And that is a big boom because that means there's more expertise out there. So we have a certain place in this treatment team that we have a certain expertise. That's what we do, okay? And there are only so many of us. And so that's the bottom line. I will give you a social comment about this also, which is go and try and get an insurance company to approve therapy, individual therapy, with a psychiatrist. Won't happen.
How often does just one psychiatrist make this definition as in our grandson? After all the evaluation, he has schizophrenia.
Mm-hmm.
I would feel more assured with 2 out of 3 psychiatrists. I think because 3 of you could probably examine him and possibly come up with a different diagnosis.
It's certainly quite possible because once again, they're not easy diagnosis. Once again, we're diagnosing on a movie, right? And it depends where you come in on the movie and your interpretation of that movie. If I could do believe me, I wish I could do a blood test. I wish I could do a scan. You know, that's what we're waiting for, right? It doesn't exist now. You know, we talk about, what are the neurotransmitters we talk about now? Norepinephrine, dopamine, serotonin, glutamate's kind of, we're waiting for that magic glutamate drug. Maybe you'll hear GABA, right, for anxiety disorders, a couple more. Do you know how many neurotransmitters are in the brain?
Billions.
Probably billions. What we know of now is 400 to 500. So do I have any illusion about, oh, I'm so wonderful and I know how to pull all the strings? No. What I know I can do is I can try and help that person as best I can, given the current limitations. Right? That's what I can do. And I will tell you, let's take somebody who has had a stroke, right? There are things we can do for people who have strokes. If you get to the ER within 2 hours, that's a pretty small window. There's a little more we can do depending on what type of stroke, right? Once you get past a certain point, what can we do? Well, we can do physical therapy. We can, look at comorbid conditions like hypertension, heart disease, diabetes, all those things that set people up to have strokes. But do I have a medicine for you that I can give you that will make you whole again? Don't have it. Not yet. Not yet. I saw a movie last week that, there was this nice scanner, somebody in space, and don't I wish I had that?
Yeah.
Yes, sir.
I just want to take a quick moment because I still don't understand the term algorithm. Is that like a protocol?
Yes.
A sequence that you go of examining certain characteristics?
Correct. It's based on what medications, based on what symptoms do you try first, then based on the response or the side effect profile, then you would go to sort of the next level.
So this is like a pattern, right?
Yeah. Yeah.
And is it reliable?
Yes. Yes. Both the APA and the Texas Project. These algorithms are based on data. It is all of these are there. So the APA I can speak to in terms of there are committees. For example, there's a committee on schizophrenia. They start with the diagnosis, and they look at the data out there that can support what are the criteria for the diagnosis. And they do the same thing with each medication regimen. It is based on the most current studies that are considered valid. Yeah.
Where are these studies done? Where are you getting this information? Where are they getting that information?
Usually academic centers are where most studies are done. So it's not just one place. Frequently it's multi-center studies. One of the places can be NIMH, National Institute of Mental Health. If we would get funding, that would be really nice. But of course, especially these days, it's not seemed to be a high priority. But it's all based on that. And then that's why we have versions of DSM, right? We're up to DSM-5 now, just came out. It takes about 5 years to go through the process from going from one version of DSM to the next. Because it takes in they have to take in all this data, they review everything, and they come up with what they believe is the best consensus at this time.
Dr. Pieri, would you just tell people what DSM is? So
Oh, sure.
The acronyms.
Sorry. DSM is the Diagnostic and Statistical Manual. So it is the manual for diagnosing psychiatric disorders. Okay? It is revised regularly. There was at one point in time a DSM-1. We're up to 5 now. Usually then there's usually a 5R, like there was a 4R, a revised version. And then the next version tends to be a major revision. Okay? So you can, it's easily accessible. It's probably not the best bedtime reading, I can guarantee you. But if you get the big version, so there's a little teeny version that just kind of lists things, and then there's a bigger one that actually explains in many ways what the basis of the way of looking at this is. And then in the back, there are the appendices. And what that is are frequently those things that have not risen to the level where the committee feels it can say, yeah, this is what we should do. But they're thinking about it. It sort of gives you what direction are they going in. Some of you mentioned borderline personality disorder, okay? In this version of DSM, there is an appendices which takes a totally different conceptual approach to personality disorders than what is the way it looks now. Okay? Very different view. It is in many ways much more complex, but I think more accurate because it looks at what they call realms of functioning. It's much more sort of three-dimensional. But the committee did not feel they had sufficient evidence at this point to make that major change. Okay? I fully expect in the next DSM that change is going to be made. Okay? So,
Says that's leading to a more comprehensive diagnosis and or treatment for personality disorders, or at least that's
the
where
whole.
you see it going.
Right. The importance of diagnosis is it then can help lead the research, right? The more precise you can get about diagnosis, the more precise your research, the more precise then we can develop medications. It follows from there. Yeah. Does that make sense? Mm-hmm. Okay. So, like I said, the slides really are more take-home. I won't go through all the factors, but when you read them, you can see...
Could you talk a moment about therapy?
Yeah.
That's sort of where you were when we began the Q&A.
Yeah. Therapy in terms... remind me.
Therapy in terms of the psychiatrist prescribing, but that's only part of the mental health
Absolutely.
response, that therapy is another dimension of it.
Absolutely.
That many psychiatrists recommend using, or
All of them should, whether because so let me talk about therapy. I'm going to take a step to a different diagnosis because I think it's a little easier to understand where therapy fits in. So I'm going to talk about depression. Okay, I'm going to talk about major depression without psychotic features. Okay, so this is somebody who has a clear major depression, recurrent episodes, interferes with their life, and they need treatment. Okay, so let's say we go through an algorithm. I, of course, have one somewhere here. Yeah, there it is. There. So I've got an algorithm for that, right? It's like I've got an app for that. Same idea, okay? I've got an algorithm for that. So let's say we work through this algorithm. We get somewhere in here. We found a really good medication treatment regimen, okay? Do I expect that if I find the right medicine, they're going to come in and say, life is wonderful, everything's great, and you know what, just fill my prescriptions and that's all I need? What do you think the percentage of time that is? Not very much. Why? For several reasons. If you are so depressed, it has an impact on your life. There's fallout that happens from these things. So you have to then process and work through that. That's stressful. If you've been so depressed you've lost your job or it's interfered with your career, you've ruined relationships, you've had your spouse leave you because of some of the symptoms, then what? So fine, I've helped the biology part, but I don't have the pill to give you a new career, give you a new job, right? And therapy also, when you're depressed, there's a way you look at the world, what we would call a cognitive function, right? You look at the world in this depressed way, right? You tend to be negative, you tend to think of things aren't going to work out, you can get hopeless. Okay, so I have a medicine to help lift that, right? But if you've been depressed for a significant period of time, medicine alone is not going to change the way you think. That's where you need therapy. That's where cognitive behavioral therapy comes in. Yeah, sir.
And follow up to that, do you think that the therapeutic component should be in the initial contact with somebody who's having behavior problems, should be focused on really intensively before even getting into the medical model and seeing whether there are these physical, these experiential and existential causes for brain changes?
No, I don't think that should be. And a matter of fact, I think that approach could be harmful for some people. If you, some of the most severely mentally ill schizophrenics, I'll just use that as one diagnosis. If they are so paranoid, if they are hearing voices so much, they can't function in therapy.
Right.
We can go back. I can take you back to early in my career when we had lithium, chlorpromazine, a few tricyclics, and Depakote, right? And the main type of treatment was psychoanalytic psychotherapy, right? And they had these great places, Chestnut Lodge, Austin Riggs, McLean, wonderful hospitals, great grounds, wonderful therapists, very smart people. And you know what? They would be there for years and years and years. Because fundamentally, the nature of the illness is when it's that severe, you can't process things. That's part of the problem. So now, once you get somebody's symptoms, a little bit under control, absolutely, I believe in therapy and intensive outpatient programs and all of that. But it's a very different type of therapy than what I'm going to recommend for that person than what I'm going to recommend for somebody with major depression.
So do you think that the initial evolution of these conditions like schizophrenia comes initially from a failure in the brain or some misbehavior in the brain, or can that be created by the experiences they have in their mind?
I think it's multifactorial. And that's why I think right now we don't have like the treatment for schizophrenia. Okay, there is certainly people where it is genetic. No different than high blood pressure, high cholesterol, because I can show you family histories that are as solid as any solid history on somebody with cardiac problems. There are other histories where this seems to kind of come out of the blue, right? Or there's just this very vague family history. However, in this individual's life is a trauma history, a childhood trauma history that is quite severe. Abuse, neglect, parents who were on drugs, moms who were on drugs when the child was in utero. Injury. That then creates what we would an epigenetic environment where under other circumstances this genetic vulnerability may have never been turned on. But under those circumstances, once that switch is flipped, there's no way of unflipping it.
What about the use of drugs as a trigger?
Use of drugs can be a strong trigger. Now, it's always a tricky question, right? Because we do know that people with mental illness, especially as they begin to have symptoms, if they're in their adolescence, right? Are they using drugs because they're partying, or are they using drugs to self-medicate, right? And we try and figure that out, but frequently they're trying to self-medicate. you know? And so is something already brewing under there? And it's just, the term would be prodromal. In other words, it hasn't hit that level yet where we could say, oh yeah, this is schizophrenia. But we see a lot of signs that suggest it. So at UNM, we have a program called the Early Intervention Program, and it's in conjunction with our child program. We have a large child division. And what they try and do is find children that are 13-ish up, and they keep them in the program up till 21, where they are seeing symptoms early on that suggest that this is what could be going on. And what can we do early on? Is there a way of preventing it? If we treat it early enough and in the right way, before it will truly take off? Or can we mitigate how severe it'll be? You know? And so it's a fantastic program, because that's ultimately what we'd all like to do, right? Is mitigate anything.
Sometimes the diagnosis is THC-induced psychosis or drug-induced psychosis, but then later the diagnosis, after they've been off drugs for a few months, then they're still showing signs of psychosis. So what came first? Was it the drugs that induced? Was it the psychosis?
And at some point, to be blunt, it doesn't matter. It really doesn't, because like I said, that switch got flipped, and there's no going back.
So if they're not doing drugs and they're still experiencing
And
psychosis,
you know,
that's when the medication is prescribed? Because
well, so let's say, let me think of a clinical scenario. Okay, so I get an 18-year-old in, first psychotic episode, comes in hearing voices, paranoid, but they're using meth. Okay? So what's my first thing I need to do? Well, I need to try and help them not be paranoid and hearing voices, because think about how horrible that is, right? And very closely second, but probably right next to it, is get them off the meth, right? If I can get a 6-month period, for sure, that gives me the ability to then say, okay, let me pull back on the medication, and let me see what begins to happen, right? If we begin to see symptoms, chances are that's not the drugs anymore, right? And there's very good literature about THC in particular increasing the likelihood of paranoid symptoms in people predisposed to mental illness. Not just anybody, but people who are predisposed, okay?
Which drug are you referring to, methamphetamine or prescription medication prescribed drugs at a pharmacy or over the counter?
It doesn't really matter if that person is abusing that medication to a degree where it's affecting their mental status. I mean, opioids are prescribed medication. We see the problems that people get into. So there are many drugs of abuse out there that can end up in the same place.
I heard also about a blow to the head.
Yes, absolutely. Trauma.
Trauma to the head.
TBIs, traumatic brain injuries. This is where I talk about a trauma-based. If you have a little kid who's 8 years old, who's been beat around by their parents, right? What do you think that does to their brain?
Nothing good.
Nothing good, right? And so you've not only got the psychological impact on that child, you've got the physical, medical impact on that child. And let's say, oh, by the way, there's domestic violence in the house. And, this child grows up seeing dad come home drunk or high and beating up mom. Now, I'm saying that in a somewhat sexist way because it's not always that way. We think of it that way, but the majority is that way.
The numbers show that.
Yeah, but once again, one of our jobs, my job, is to never assume anything, right? Because if I start assuming things, I could miss those clues that can tell me a little bit different approach that I can take or should take, right? But that poor kid, how do I go back and erase that? I can't. I can't erase that, right? So that's why these factors are so important. And those biological differences, I'm going to dovetail to tie this into last year, how hard it is for somebody to have insight, right? Because your brain's not working right to begin with. And you want somebody to get the concept of mental illness, the specific illness they have, and let's say they're 18 years old. Think about normal 18-year-olds, right? Separate if you have an illness. How many 18-year-olds do you know can think they're, invincible, right? They don't need you. They don't need anything. They're going to conquer the world. They're going to go out and party, and they'll be fine the next day, right? That's normal.
They think it's normal.
It's normal for an 18-year-old, right?
In our culture,
Yeah. So that's what you're working with to begin with, right? And then, of course, if you're their family members and you're watching all of this, right? And you're saying, oh my God, I am so scared for my kid. Why won't they listen? Why don't they see? Right? How many people have been there or continue to be there? Right? But it's so hard to understand that that's part of the illness. And that's where we get into the more ethical debates about people's rights versus what's illness, what's not. And I'm sure many of you have experienced those situations where you want to grab the psychiatrist by the neck and say, why won't you do something? Right? How can you not do something? Why won't you keep this person? Believe me, 98% of the time, I'm on the same page, but I can't. We are a society that values civil rights. And civil rights trump mental illness. That's the way it's structured.
I don't think we value civil rights more than the overpaid price is required research and development.
That's the other side. I'll have a drink with you to talk about that.
Several times, I guess over the last year or so, I've heard the statistic that 20% of the American population is being treated for a mental disorder. Mm-hmm. Is that accurate?
Yeah. Yeah. Now you have to talk about incidence and prevalence, okay? Because the statistic, you have to ask what that means.
Yeah, I
okay?
know. And
so
I'm asking, what does it mean?
Yeah. So at any given time, 20%. Now you're including everything, right? You're including.
Well, I don't know what
Yeah.
that statistic includes. Do you?
Yeah, it includes everything.
Everything, like I'm worried or I'm, just
Yeah.
mad because I broke up with
Anxiety
my girlfriend.
disorders, traumatic
Can't
grief. Yeah. So, anything that would qualify. So that's a pretty broad thing, right? Because, how many parties do you go to and you're talking to your friends and they're having a stressful time and, but that's, so it kind of that's a really broad.
But it uses the term mental illness, like there's a illness we normally think of as a biological misbehavior, whereas it may just be the effects of grieving, stress, coping, having a hard time coping. Those are just things that we normally do, but now we medicalize them, right?
To some degree. I mean, American medicine is prone to give a pill quickly for almost anything. Yeah, I don't think psychiatry is an exception to that, But, so in those situations, let's say your spouse is terminally ill, okay? You can't sleep, good reason, right? You're very anxious, you're depressed. There is a place for medication, short term. Right? Because if you're not sleeping and you're dealing with this horrible situation, it makes it 20 times worse for that person. That doesn't mean that that's a long-term solution. It doesn't mean somebody shouldn't be in therapy, really, as the primary issue, right? But don't discount the short-term use of medication as a tool in the toolbox. Because making somebody suffer is not a good solution. If you're so sleep deprived, you cannot think clearly. How is that helpful? You can't process your grief. You can't do anything. You know, and so it really is looking at the context, you know, of what to do. So I'll give you another little example. So pain medications, right? We are in the midst of a huge opioid crisis. Opioids, when I was in medical school, the way it was taught, no one should ever be in any pain at any point in time. Period. End of story.
No wonder we're a mess.
You're right. But that was what we were taught. And you know what? The Joint Commission and all those other organizations that evaluated hospitals, and those little smiley face pain things, you know, where you're sad if you're a 10 and you're really happy if you're a 1, you would get those hospitals got evaluated about how many pain scales they were. So if you were a patient and you walked out of that hospital and you gave them a frowny face because you had left them in pain, that worked against them. Now, we know now that was really not a smart move, right? Right? There is still a place for opioid medication. If I'm replacing your knee, I don't think you want to have no pain medication. But do I think it's reasonable to think that after 10 days, 2 weeks, we should be pulling off the opioids and using other types of medications that are non-addicting? Right? That seems reasonable. Because I don't want you to be in severe pain. I also don't want you to get addicted to opioids. So it's the same idea with these other types of treatments. Is absolutes, I think, always put us into bad places. Because people don't fit boxes really nicely. So.
I don't know if this is off the topic or what, but I have a question on the medications. You were saying that like lithium, that's been around since like day one, right? What are the newer? Are they coming up with anything besides, you know, lithium and Depakote? I mean,
so do you know what's the most effective medicine for bipolar disorder? Lithium.
I've heard horrible things about lithium. I've heard from a nurse that I know that said, well, put it this way: if you have to get your blood checked every 30 days or every so often because it's so poisonous, how could it be a good thing?
So, do you know lithium's in all of our bodies? It's a salt. It's a natural electrolyte. If I took lithium out of your body, you'd die. So, we are using it in hyperphysiological amounts. Okay? You're right. It has side effects. It has short-term side effects, and it has long-term two predominant long-term side effects that we monitor for. Hypothyroidism, which actually we can replace that. The one that is really more concerning is it can cause kidney damage. Okay?
That's what I find unacceptable. Is that, I mean, for my son, I don't want him on a medication that is going to subsequently cause him other health problems.
Would you rather have him symptomatic?
No, I'd rather have him on a drug that doesn't cause horrible side effects.
I can't give you one of those.
And the other the secondary question I have.
There are, but there's valproic acid, which can cause agranulocytosis. We monitor for that. There's oxycarbamazepine, same thing. Lamictal, which is a great medicine for bipolar depressed for some people who get only hypomanic. You can get Stevens-Johnson syndrome, which is a rash that can be so severe, it's like a bird. Now, let's go through your cholesterol medicines. Let's go through your blood pressure medicines. If you have cancer, you want to go through the chemo meds? Okay? We're in no different place than anybody else. It's a cost-benefit ratio, right?
To that point, how much is the psychiatric research branching out into alternative rather than pharmacological solutions to mental health?
So at UNM, I can tell you, we have an integrative medicine course that all the residents take. It's part and parcel of what's taught. The studies do not support its use alone.
Well, for example, several years ago at the National NAMI conference,
Mm-hmm.
heard one of the longest longitudinal studies on bipolar disorder that's being done in Michigan. I can't remember which university.
Probably U of Michigan, because it's got a great, yeah.
And there were two presenters, and one of the people presenting was really focused on the gut and the
Yes.
microbiomes
Yeah.
in the gut.
Right.
And I don't actually remember what the other person was focused on because I was so fascinated by that because it was so antithetical to the approach that is traditionally known to. And I think a lot of us that either have a diagnosis or have a loved one with a diagnosis see this constant push-pull on these medications that are relieving positive and negative symptoms but have all these other side effects. And that creates lack of
Compliance. My son isn't gonna
compliance.
take them because of the side effects.
And you know, the weighing is, to me, we still have work to do, in
Oh.
my opinion, to weigh what is the most,
So what you're talking about, the gut flora studies is what you're talking about. And it's sort of it's not new, it's been around for about 5 years now. There's a lot of studies going on, and what it's related to is the theory of inflammation. And if there's inflammation in the gut, is there also inflammation in the brain and different sort of factors, cytokines and things? It's very interesting research. Great. Has it translated into any reliable therapies? Not yet. You know, one has to be very careful about looking at research and theories and how that then gets translated out into practice. So I'll give you a very real-world example today, S-ketamine. How many of you have heard about S-ketamine?
I was gonna ask you about the ketamine. I know only as ketamine.
Yeah.
But is it the same thing, S-ketamine or
So
ketamine?
S-ketamine is now the FDA-approved treatment. So it's a analog of ketamine. It's really ketamine, and if you metabolize it, it metabolizes into ketamine and S-ketamine. So S-ketamine is FDA approved, and it doesn't require IV administration. It's actually a nasal administration. The therapy course is generally about 2 treatments a week for about 4 weeks, and then you go down on it. Now, my clinic, I mainly deal with psychotic disorders. But my clinic, because we have long-acting injectable clinic, I have a lot of nurses who work with me, and so we're the administration site at UNM for S-ketamine. And I work with another psychiatrist, a couple of them on that. Once again, the hype about S-ketamine is amazing. And I can tell you, I've seen some amazing results from the patients that have come in.
Well, maybe that's why it's
Depression.
hyper.
It is only approved for depression.
Oh, I thought it was also for bipolar.
Once again, the FDA only found enough evidence based on that for depression. I have seen some amazing results, and these are really treatment refractory patients because they have to fail at least 2 antidepressants, but it's still only got a 50% success rate in what I'm seeing right now. Okay?
So somebody who's getting ketamine on the street and is loving it is self-medicating. Their dosing.
Could be. You know, ketamine's been
It's
used.
become a popular drug on the street.
Yeah, well, it used to be, to be honest, when I was a kid, too. I mean, if those of you who are old enough might remember, in the party drug culture, it was called Special K.
Yeah.
Oh.
And oh, there you go.
We thought it was just fiber.
Yeah. And if you remember, you would hear of people going into K-holes if you were at parties, and they would talk about Special K, but certain people had really bad reactions. They would go into what's called a K-hole. Well, a K-hole was frequently, in those days the term would have been a bad trip, but it was the severe dissociative reactions that people would have. Okay, that is a potential side effect. Not that severe. It's usually really mild with S-ketamine. But once we administer the medication, the patient has to be observed for 2 hours before they're allowed to leave. Okay.
And side effects?
Actually, it's pretty well tolerated. Some sedation, dissociative symptoms early on, but once again, usually by the time they leave, they're doing okay. Here's my caveat. When was this medication FDA approved? March. We're not even at a year. And every time a drug is approved, the way it behaves in the real world compared to the way it behaved in the studies is dramatically different, because you can't screen the real world like they do for studies. So here's another question. We know ketamine can be an addicting medication, right? Do we know if you are on S-ketamine or even ketamine treatment for 2 years or 3 years, is there a point where the therapeutic effect shifts into an addiction? We don't know. It's one of the big questions, right? Does that mean I shouldn't give somebody who literally is suicidal every day of their life that opportunity? It's cost benefit, right? Right? And that's what we're really talking about on any of these things. There is no perfect medicine.
So you mentioned the difference in the studies, between the studies and the effects in the real world. One of the things that's become of interest lately is so many of the studies are male only. Do you see an effect of male only tested diseases not working for females? And is that an issue in the drugs you use in psychiatry?
Sure, and a lot of times it's dose dependent, and this has been an issue for a long time.
It's not just in now.
No.
It's lots,
Yeah.
it's not just in.
Yeah.
They don't
Medical
test
studies.
for
Yeah.
women. They haven't done
Yeah.
a lot of studies.
Even
So
now,
women are too complicated,
That's
is what
right.
they say.
yeah,
Program thought, right?
yeah. Even nowadays, there's far more focus than there ever used to be on women's health, specific, and even in psychiatry now, there are psychiatrists who are specializing in women's mental health issues. And there's a program, there's a psychiatrist, Nina Gonzalez at UNM, who's developing that program. Because the physiology is different, right? The hormones are different, everything. So there's more attention to being paid to it. Is there as much as should be? No. But I can say the same thing about, what about ethnic differences? What about racial differences? Not everybody is the same by any stretch of the imagination. Socioeconomic.
Hear more about ECT being used.
ECT is a fantastic treatment.
What is that? Is that the magnets?
No, that's the electroconvulsive therapy. It can be life-saving. Everybody has a bad impression of ECT because everybody's seen One Flew Over the Cuckoo's Nest, which is, if I could burn that movie.
It was not that untrue. That experience was not that untrue
No.
in another era.
In another era. That's the caveat.
Yeah.
In another era. Okay? Nowadays, it's done under anesthesia. You're monitored. It's dose-related in terms of the stimulus. The seizures are controlled. It's very different than what you saw in the past, where it was done without anesthesia and you were held down, and that doesn't happen now. And what I like to tell people is, do you know how they did colonoscopies when they first did them?
Without anesthesia.
I'm not sure. I want to know.
So I go there.
Yeah, but that's true. Everything evolves. Why is it when people think about mental health, somehow their brain gets fixed at a certain point as if nothing ever changes? Think about it. Why is it that all of us in this room have these preconceived notions as if it's 1955 about ECT? Stigma.
Fear.
Yeah. Lack of education.
Right.
Probably because born with all 5 senses, including hearing.
Mm-hmm. Yes, sir.
You mentioned earlier that in some cases, or most cases, that without the medications, that therapy is really pointless. What about a situation with someone who has had mental health issues for years.
Mhm.
And then they experience a traumatic moment. And that seems to trigger a deep dive into psychosis and then
Mhm.
other. Would it help to try to treat the PTSD like some of the therapies that are available for PTSD? I remember reading about one where they lead your vision off to the side.
Rapid eye movement, yeah.
Yeah, and would that benefit someone?
You know,
Would
I-
they be receptive to people?
Well, they have to be receptive, right? And it depends on their symptoms, right? In order to engage in therapy, you have to have some ability to attend to the therapy, right? So, what's their level of ability to just basically focus on therapy, right? And I don't want to say that don't do therapy. If someone's refusing medication, but you can get them in the room to talk, hey, bring them week after week, month after month, because as I develop a relationship, and maybe as that person begins to trust me, maybe I can convince them to try a medication, right? So I don't want to sound, I'm not making absolutes, because I think there are so few absolutes. But I think there's a certain way of thinking about things.
Doctor, what do you look for in like recovery programs to make sure it's a good, valid program? A lot of them, these private programs, are extremely expensive.
Oh, yes.
And
And not effective.
if you were starting out with your son or grandson, how would you evaluate a program? The costs are just
Astronomical.
astronomical, and you want to make sure what you can afford. And how do you evaluate? If I tell you someone's going to a certain program, what would you use to evaluate?
So I'd say a couple of things. So let me make one hopeful comment about alcoholism and substance abuse. The research going on about biological interventions to help people in those early recovery periods are quite interesting and quite phenomenal right now. So that's one thing. So there's this whole side that's being developed that was never
Getting people on the right medication to help with
using
substance abuse.
naloxone for alcoholism in terms of cravings, using Suboxone to help people, all these things. It's still really early, but some of the data that's coming out is much more hopeful than we've ever had before. Because once again, when you think about addiction and alcoholism, don't you get kind of judgmental?
Yeah.
Right? And even though, you can say the line about this is a biological illness. We know certain triggers have occurred. You can't just take that back. Because if you're an alcoholic and you've been drinking and you become sober, right? And you're sober 10 years and you relapse, how quickly does it take you to get back to that tolerance? Not long. Not long at all. And that's biological, right? So there's all these biological, but boy, are we judgmental, right? Why don't you just stop? Right? So, having said that, what do I look for in a program? I would look for a program that, first of all, does a sophisticated intake. That they look not just at the substance abuse and the history of it, which I think is important, but are they also really doing a good diagnostic interview if there are other psychiatric conditions, either primary or secondary, that may be interfering with that person's ability to participate in treatment? That if somebody's bipolar, right, and I take them off their substance, but I don't treat them for their bipolar, good luck keeping them clean and sober. And is the place that you're looking at, for the money you're paying, looking at this whole picture? That's what I would look at. Is there not only good group treatment and things like AA, but if I'm going to be paying prime dollars, is my family member getting individual therapy? Because if they're not, why am I paying all that money? Where's my individualized treatment?
Is that kind of like a better business bureau for some of these, for some of these centers?
Well, there's,
I mean, I see the
accreditations,
point.
right?
Yeah,
It's
yeah.
accredited by-
Yeah, so that gives you to me, what that says is you have a bottom.
Yeah, it's a-
Yeah.
It doesn't tell you the top.
Right.
Well,
Yeah.
and each patient situation is different, what works for, it's just like the therapist or.
Right.
Not
Right.
the program will be right.
Right. Yeah, there are some.
But too often, this is my own personal view, this is not a professional view,
Mhm.
is that I think that it is possible to step back and assess what is the primary objective of the people that run the program. Are they interested in making money, or are they interested in helping people? And that honestly isn't that difficult to get to if you're careful in how you ask questions.
And I would add a caveat to that. My philosophy throughout my career is if you give quality care, you don't need to worry about the money.
Exactly.
Because if you're giving quality care, you have got more people coming to you than you're going to have time to deal with. Right?
Another criteria that we're just starting to see is a lot of these programs are utilizing what are called peers, frequently certified peers, which are people who have had the problems themselves and are either in a stable treatment or in recovery from the drug abuse. And what we're seeing is the reviews of the programs with those peers are much higher. Christus has a gentleman who is a peer, who's in the behavioral health unit as really a support person. He gets the highest ratings from the people who fill the exit surveys out of any other person on the unit. And it's just, I think where peers are willing to work, typically tends up being a place where, what Terry was saying, people care about helping people more than they care about just making money.
That's common sense. Somebody
Yeah.
who has experienced or recovering from has a greater ability to develop empathy with somebody else.
We have a whole peer department. So there are peer support workers which have less training, but there are also peer counselors. And those are usually paid positions. Peer support workers tend to be volunteers.
They can be both.
They can be both, but
The new Medicaid rules
have they changed that?
They
Yeah.
Yeah, well, that's good. Yeah.
I would also add, if you're a family member, what I saw when I sent my son to a place, if they end up with a relationship with a professional there where they trust and they're willing to work with them, but if they're fighting it all the time and you're kind of wondering, there's nobody there that they really connect with, I would question that.
Well, the other problem, and this is, I think, also where frequently families struggle, right? I can have the best program in the world, but the first step has always got to be that person with the addiction has got to say, I have got a problem and I want help. That is the biggest factor.
We need to probably wrap up in a few minutes. I mean, it's fantastic, and we could go forever, but.
We have to be out of the building.
No, we've got some time, but I
Yeah.
just, I want to start the end rather than be in the middle.
Is there a program to help people in a situation with someone you're caring for? That's anosognosia, or denying their symptoms.
Yeah.
Is there a counseling program to help people I know NAMI has a great.
I was just going to say,
but I was
you're
thinking
here.
of something every
Yeah.
professional we've been to, including
Yeah.
psychiatrists, psychologists, police, lawyers, medical doctors, the bottom line with all of them when we try to discuss the situation is good luck. I'm so sick of hearing good luck.
It's unfortunately a very unempathic response.
Is there an algorithm?
Yeah.
But is there a counseling program to assist us in maybe knowing how to better nudge our son to somehow to the point where he might agree to go?
And I'm on, when I said NAMI, that's where I refer people to all the time. I try and get people to go to their local NAMI meetings. I hope they get involved enough that they'll go to the national meetings, because that really is the best thing. You know, you may find an individual therapist or counselor, but once again, not necessarily. I mean, unfortunately, sometimes the best advice you'll get is from people who have been through it or are in it right now.
That's the peer thing, right?
Yeah.
That's another
Yeah.
version of Pieri.
Yeah.
There's a program called CRAFT, developed at UNM, which is very successful for family members helping people with addiction. Is there any thought of developing a similar program for family members of people with mental illness? I mean, I talked to the originators of CRAFT, and they've retired, so they're not going to develop anything more.
Yeah.
But they didn't know of anyone who'd ever tried to apply that to family members of addiction.
It's a fantastic idea. I wish I told you we were able to start developing that. If you know a grant I can get to hire the staff to do
There's
it.
already a program.
Huh?
There's already a program. It's called Open Dialogue.
Mm.
It evolved in Finland, and they actually began with the people in the northern part of those countries, the Sami people, the reindeer herders. They had their own process for dealing with mental illness, very successful. The Pieri group, and of course they live in tribes, so it's easy for them to form a concerned body of people who are their peers.
Yeah.
Now, there is a guy here in town, his name is Kermit Cole, and Betty has met him, I think, who's trying to do that here. But he's finding it, and he's Danish. But he's finding it much more of an uphill struggle in our atomized society. We are all individuals. We hardly exist in family structures anymore.
Yeah.
We're all running around and, we hardly even know who our cousins and our sisters and our aunts are.
Yeah. There are.
So that makes it tough, but
Yeah.
I'm actually getting to know him and trying to see if I can get him to participate in my son's further treatment,
Yeah.
and I think he may be helpful.
Scandinavia has a lot of great programs. Not
Supposedly they have like about an 80% successful outcome.
right, but there are so many factors. The question is, what can we take from their experience, translate it into our culture and our healthcare system?
Well, this we have to do on our feet.
Yeah.
We're not going to think it out. We're going to just do it.
Yeah.
Make our mistakes and grow.
You had a question in the back?
Yes, I was recently reading a pamphlet that dealt with maintaining good health through the aging process, and one of the articles mentioned some very specific benefits of being out in nature.
Mhm.
And my question is, has there been any kind of measurable research that sort of thing can be helpful with certain mental illnesses?
Well, let's go back, you want to go back 50 years where we threw out the baby with the bathwater? There were a lot of things that were bad about the old mental health systems. There were also some things that we lost, which was in campuses of people with severe mental illness where they had a job, they had their place, they had a home that was safe. They were able to garden or do whatever their thing was. Also, the studies about exercise and the benefits in whatever form, right, no matter what, are hands down very clear. The problem is, what's one of the symptoms of many of the mental illnesses? Low energy, low motivation, lack of interest in things, right?
But still, those communities were healthier than what we have now.
Absolutely.
Almost.
Yeah. I could keep talking all night, and I won't. And you know.
Why don't we take one more question and then
Sure.
give you a chance to close? Did you have one?
I had another question about a diagnosis and the algorithm. Is there a case where you'd have a patient where you start them on an antipsychotic, a certain dosage, because you can determine try it out for 4 or 6 weeks, whatever it is, to let them
Mhm.
stabilize on it. At what point do you know, or do you experiment or try to taper them down? You said you like to try to get them at the lowest dose. How do you determine when they're ready and how, and
Right.
eventually, can they come off that medication?
No.
No, ever?
No.
If they have
If-
a diagnosis of.
No. So we used to do that all the time, early in my career. The conventional wisdom was you got somebody on medication, you got them symptom-free and stabilized, and you started reducing the dose, and at some point you would try and stop the medication. Okay. So the first point I'll make is we use higher doses in acute psychotic situation, like inpatient, right? Once they come outpatient, we are going to try and lower the dose because we don't need, maintenance doses generally are not as high as you need in acute situations, one. Okay, so we do that. However, the studies now are hands down. If you are sure of your diagnosis, okay, that's the key. If you are sure of your diagnosis, and you take someone who's schizophrenic off their antipsychotic, the percentage of relapse to psychotic within a year is like 80 to 90%. Not only that, but getting that person to be you would think, okay, fine, then we just put them on the medicine, we get them at the same dose, life will be fine. Nope. There is some evidence that the more psychotic episodes someone has, that there is a deterioration that occurs, and you can't necessarily bring them back up to baseline.
How do you know if your diagnosis is like you said,
It's where the
you're
art is.
working on a movie, not on a snapshot.
Yeah.
So
Right. And that is the art. And like I said, I hope I'm still alive the day that we have blood tests and we have scans and things that can make us assured of some of these, or genetic testing. There's a lot of
you just
possibilities.
have to work on observation.
Yeah.
Dr. Pieri, closing comments, please.
No, thank you for having me. I have always enjoyed coming here.